Okay, without further ado, I'd like to introduce the next speaker, who is Ron Klein, who is well known to all of us. Ron is an epidemiologist and retinal specialist at the University of Wisconsin and is author of many population-based studies on age-related eye disease and diabetic retinopathy. And this morning we'll be talking to us about the prevalence and incidence of AMD and definitions and grading of AMD.
Thank you. It's a real pleasure to be here. I wanted to thank the organizers of the meeting for the invitation. I'm going to focus on early AMD rather than late, because the object of the game is to prevent visual loss. Once you get to late AMD, you've really missed the boat. From a patient's perspective, they have a number of questions when they're told they have early AMD that are listed here. What is the risk of progression of their macular degeneration? Is this something they did or was exposed to that resulted in having this condition? Is there something that they can do to prevent progression and blindness from this disease? And what is the chance of their siblings or children getting the disease? Epidemiology provides information on the prevalence, incidence, and natural history of the disease and its relationship to visual loss, which has important prognostic implications. I'm going to discuss a number of these risk factors that are listed here in the slide, such as lifestyle factors of smoking, drinking. I'll leave the diet to others. Medical conditions and medications, such as hypertension, cardiovascular disease, inflammatory disease, and statins. Environmental exposures, ocular factors such as eye color, and genetic, familial, and racial ethnic factors. I'll start with the question, what is the risk of progression of AMD? A number of population-based studies, some of which are listed here, have looked at this in recent years, including the Beaver Dam Eye Study, the Blue Mountains Eye Study, the Los Angeles Latino Eye Study, the Rotterdam Study, and the Copenhagen City Eye Study. They've all used the 30-degree color stereoscopic fundus photographs. And these photographs are graded using the Wisconsin Age-Related Maculopathy Classification Scheme, or a modification of that scheme. John asked me to discuss how we grade fundus photographs. This is a composite showing 3 standard fields. Field 1 focused on the disc, field 2 on the macula, and field 3 temporal to the macula. We use a clear plastic grid. Now that we do digital imagery, we place the grid in the computer, focus centered on the fovea. And we use different circle sizes. First 3, 63 microns in diameter, 125 and 250 to define the size of drusen, and various other size circles to define the area and extent of the drusen and pigmentary abnormalities. This picture shows an eye with early age-related macular degeneration with pigmentary abnormalities. And we define early age-related macular degeneration by the drusen size, type, area, location of the drusen, and by pigmentary abnormalities, including increased pigment, RP depigmentation, and area and location. I have this figure here which shows the circular grid. The central subfield is defined by a circle of 300 by 1,000 micron diameter. The inner subfield by a circle of 3,000, and the outer subfield by a circle of 6,000 diameter microns. And this area here is a circle of 500 micron diameter, which defines a degree of severity of or extent of large drusen, which are graded and fit either within the circle, less than 500, or greater than. And there are various schemes of area that people have used. AMD can be categorized in 3 levels: as early AMD, late AMD, which is pure geographic atrophy, no AMD, early AMD, or late AMD, 2 types, pure geographic atrophy or neovascular AMD, or up to a scale of 15 steps, depending on the definitions. I'd like to briefly talk about, since a lot of the data I'll be presenting this morning come from Beaver Dam, about the study we've been doing for the last 20 plus years. Beaver Dam is a small city 39 miles northeast of Madison, where the university is. We selected Beaver Dam because of the population. It's very typical of the population of small towns in America. And the compliance with, in earlier studies, with very high participation rates, and the 100% participation of the optometrists and ophthalmologists in the study. From 1987 to 1988, we did a private census, which we identified 5,924 individuals who were 43 to 84 years of age at the time of the census. From 1988 to 1990, we did a baseline survey of 4,926 individuals, or 82% participation. And from there on, we've been funded by the National Eye Institute every 5 years to go back. You can see the declining numbers, which represent the mortality in this age group. We've had 82 to 85% participation of survivors throughout the study. The population is largely white, with very few non-whites in the cohort. This slide presents the prevalence of early age-related macular degeneration defined by the presence of soft indistinct drusen or small drusen with pigment or larger drusen with pigmentary abnormalities. What you can see at the baseline in the 43 to 86-year-old age group, 19% had early AMD, 14% had soft indistinct drusen, 6% had a large area of drusen, 13% had pigmentary abnormalities, and 3% had large area of drusen and pigmentary abnormalities together. And the prevalence of late AMD was 1.7%, 0.5% had pure geographic atrophy, 1.2% had neovascular AMD. And this figure shows the prevalence of AMD, how it varies by age in men and women at the baseline exam. And you could see that it varies from a little over 10% in men, about 7% in women in the 43 to 54-year-old age group. It increases with increasing age, reaching nearly 37% in those who are 75 to 86 years of age. And for late AMD, nearly 0%, going up to about 7%, and the rates are similar in men and women. Because in 1988 to 1990, we had the upper age limit of 86. We've now seen the population, and we have a group of individuals who are in their 90s and early hundreds that we've seen in the last go-around. This is the first time these data have been presented, and it shows the prevalence of early and late AMD in those who are 63 to 79 years of age who survived to be seen at the 20-year follow-up exam. 15% have early, 1% have pure geographic, and 1% have exudative. By the time we reach 90-plus years, there's 112 individuals. 25% have signs of early AMD, 8% geographic atrophy, 13% exudative. Totaled up, it's nearly 50% of the cohort that are 90 years of age or older have signs of AMD, of which 21% signs of late AMD. It's 1 in 5 individuals. You have to realize that there are a number of individuals who we could not see in this age group. We did go into nursing homes and institutions, did home visits to do the examination, so it's a fairly comprehensive survey, but people who were badly Alzheimer's that did not cooperate or we could not see, the figures might be even higher. This shows the 20-year cumulative incidence of late AMD by types of lesions. Again, 19% developed who did not have signs of early AMD over the 20-year period developed signs of early AMD. And this shows the incidence, cumulative incidence by type, soft and distinct 17%, 16% developed large area of soft drusen, 8% developed drusen greater than 500 microns in area and pigmentary abnormalities. 5% of all age groups developed late AMD, and 16 progressed by 2 steps on a 6-step AMD scale. This table shows the relationship of the cumulative incidence by age at the baseline exam. The 20-year cumulative incidence of early AMD ranged from 10 to 24%, from 43 to 54 to 75 to 86-year-olds respectively. For late AMD, went from 1 to 10% before it dropped slightly. We looked at the 10-year cumulative incidence of late AMD in persons age 85 or older. And the reason I put this slide up is there's sort of a paradox. At the beginning of 65, people 55 to 75, there's a higher risk of developing of neovascular AMD, but when you get past 85, the risk of developing geographic atrophy seems to increase by twice that of neovascular. And this figure shows the increased risk by type of drusen, from hard distinct, soft indistinct. You could see for a given quartile range from smallest area, first quartile range, to the largest area, with those having the largest soft indistinct drusen with the largest area having a 50% risk of progressing to late AMD. And the question is, what's the risk of visual loss? It wouldn't matter if you had these anatomic changes, but the issue often is, how does it affect your visual function? So if you had early AMD at the beginning compared to people who did not have early AMD, the incidence of visual impairment defined as 20/40 or worse was 35%, with an odds ratio of 3. If you had soft indistinct drusen present only, the odds ratio was 4. If you had drusen area greater than 500 microns, the odds ratio was 6. And if you had drusen area greater than 500 micron and pigmentary abnormalities, it was 8 in these individuals compared to people without these lesions. The second set of questions is there something they did or was exposed to that resulted in having this condition? Is there something that you can do to prevent progression and blindness due to this disease? Smoking was mentioned by the first speaker, and there's a lot of reasons why smoking can be invoked as a possible pathogenic factor in AMD. It increases immune activation, depresses the antioxidant levels, alters choroidal blood flow, it decreases luteal pigments in the retina, alters drug detoxification by the RP, and potentiates nicotine has a potentiating effect of angiogenic activities. And these are all hypothesized pathogenic mechanisms. And indeed, when we looked with the Rotterdam study and the Blue Mountain study, nearly 13,000 people, cross-sectionally, people who were currently smoking after controlling for age and sex and sight, had a relative risk of, or an adjusted odds of about 5 if they were a current smoker to never smoker, but this is the 95% confidence interval, and a adjusted odds about 1.5, and these were both statistically significant for geographic atrophy. For neovascular AMD, it was about 2.5, and for late, which is both combined, it was 3 for current versus never smokers, with less of an effect in former versus never smokers. Johanna said in looking at the Nurses' Health Study, in which late AMD was identified by history over a 12-year period, showed that in current smokers who were 15 to 24 cigarettes a day had a 40% increase in the odds. 25 cigarettes per day, nearly an odds ratio of 2, and past smokers had an effect in the incidence of self-reported late AMD after controlling for other risk factors, showing an effect, a dose-response effect of cigarette smoking. Data from the Beaver Dam study showed that smoking at baseline was associated with an 18% increase in the 20-year incidence of early AMD in men and an increased risk in women that failed to reach statistical significance. However, when we looked at the incidence of late AMD, and we've looked at it at 5 years, 10 years, 15 years, and now this is the 20-year cumulative incidence, while there's an increased risk of incident early AMD, we failed to find a increased risk of incident AMD in current versus never smokers. We pondered this for a while, and it could be due to selective survival. Smokers who developed AMD may die before they're seen again in the study, or it could be due to limited power to observe a relationship between smoking and the incidence of late AMD in people aged 65 years of age or older who are at most risk. There were only 44 current smokers aged 65 years of age or older at baseline who had signs of early AMD who returned at the 5-year follow-up, really decreasing the numbers. People stopped smoking, generally, at least in Beaver Dam and in most places in the U.S. after 65 years of age. So maybe a power issue. Or it may not be related to incident late AMD. They might have been the quick responders who were genetically susceptible, who developed late AMD, who were smokers, leaving the people who were not susceptible. In Beaver Dam, quitting smoking over one exam interval was not significantly associated with the incidence of early AMD over the next exam interval. Regardless, smoking is bad for you, and basically it increases the risk of cardiovascular, lung disease, kidney disease, and keeps us in business as epidemiologists looking at relationships. So people shouldn't be smoking, regardless of its strength of relationship with late AMD. It's another Van Gogh picture of heavy drinking. And heavy drinking increases oxidant stress, may affect mechanisms that protect against oxidative damage. And I've tried to summarize the data that's extant in the epidemiologic literature from case control studies, most of which have shown no relationship. The Haynes baseline exam showed a relationship of protective effect of wine. In Beaver Dam, cross-sectionally, we found a relationship of beer with early AMD. 5-year incidence, we found beer deleteriously related to drusen incidence, and heavy drinking at the 10, 15, and 20-year incidence to exudative AMD in both sexes and pure geographic atrophy in men only. Rotterdam and Blue Mountains, where I think people drink more than in Beaver Dam, what's considered heavy drinking, which is 4 more drinks a day over a period of time. No relationship. In Lales, which is Los Angeles Latino Eye Study, wine was protective, beer was deleterious. Physician's Health Study, no relationship. Alcohol consumption was deleterious in the Copenhagen City Study. Is heavy drinking and the incidence of neovascular AMD and pure geographic atrophy in Beaver Dam real? I think we have to sort of stop and think that there's few studies that show this to be a consistent relationship, and maybe by chance given a large number of observations, or more likely as a marker for other lifestyle factors and exposures, including diet, that may not be controlled for adequately in the study. What about hypertension? There's a number of studies, that of Hyman, the Eye Disease Case Control Study, the Health and Nutrition Exam Survey, the Framingham Eye Study, the Age-Related Eye Disease Study, and the Macular Photocoagulation Study, which showed a deleterious effect of high blood pressure and hypertension, and the French Case Control, the Physician's Health, the Rotterdam Study, and the Copenhagen, which showed no relationship. And this is from Beaver Dam, and it shows the odds ratio and 95% confidence interval of late AMD by hypertension status, and shows that people who were treated, known hypertensive, uncontrolled versus normal had an odds of 2 of developing late AMD over a 5-year period. Treated controlled versus normal, 1.5. People who were undiagnosed or were found to be hypertensive at the time of exam versus normal to have a non-significant, slightly higher risk. The effect of modification of blood pressure on the incidence and progression of AMD remains to be determined. We're not sure if it's the treatment itself, which may be protective, or deleterious, and that needs to be shown. Another concept is pulse pressure, which is the systolic blood pressure minus the diastolic blood pressure. It results from an increase in the mean blood pressure associated with decreased arterial desensibility, leading to higher systolic blood pressure and lower diastolic blood pressure. This is attributed to age-related changes in collagen and elastin as people age. We speculated that pulse pressure might be a marker of similar changes in Brooks membrane and hypothesized that higher blood pressure would be associated with increased incidence of AMD when we began these analyses. Indeed, you could see higher odds hazard ratio for most of these with significant relationships with increased pigment, RP depigmentation, late AMD, and pure geographic. Having a higher pulse pressure at baseline was associated with, of at least 10 millimeters, was associated with a higher odds of about 20% for development of late AMD. Pulse pressure may be a useful marker of age-related macular changes in Brooks membrane that confer higher risk of incidence and progression of AMD. We're currently investigating the association of more direct measures of changes in the sensibility of the carotid artery and AMD in the MESA multi-ethnic study of atherosclerosis and the Beaver Dam offspring study. Is atherosclerosis a risk factor? The Rotterdam study found that in persons less than 85 who had plaques of the common carotid artery, they were 5 times as likely to have late AMD as those without plaques. The odds ratio here are the confidence intervals are quite large, 2 to 12. And we have shown in the ARIC study, atherosclerosis risk in community studies, the 2 times likelihood cross-section of having RP depigmentation. And in the cardiovascular health study, 2 times as likely to have any AMD present compared to people without plaques. However, in Beaver Dam, we've never found a relationship between angina, myocardial infarction, and stroke to be associated with the prevalence and incidence of AMD. Whether this may be due to the selective survival, people with AMD in these conditions may die before being seen in the exam, or a sample size issue, or they're not related, is not known. Currently, we're evaluating the association of carotid artery intima media thickness, a marker of atherosclerosis, measured over a 10-year examination period with a 10-year incidence of AMD. How about lipids and AMD? Lipids have been thought to be deposited in Brooks membrane and hypothesized to reduce the permeability and be a pathogenic factor in AMD. However, the literature is very counterintuitive in a way, because in a study by Leslie Hyman of cases of AMD, late AMD in controls, she found that having higher serum HDL cholesterol, the good cholesterol, was associated with an odds of 2.3. Similarly, in the Rotterdam study, higher serum HDL cholesterol was associated with geographic atrophy. And in the Copenhagen City Heart study, having higher serum apolipoprotein A1, a transporter of HDL cholesterol, was associated with late AMD. The reasons for these relationships are not known. Curcio has sort of hypothesized that they may turn off cellular mechanisms in the RPE that respond to these high levels. Lipid deposition in Brooks membrane. In Beaver Dam, the 20-year data showed no association of serum total cholesterol and serum HDL cholesterol, and the incidence of late AMD. Statins have also been thought to be related to preventing AMD. In an early study by Hall and Associates in a case control design, they found a 90% reduction of AMD progression in statin users. Similarly, there was a significant reduction in the AMD progression in statin users in the Melbourne population, as reported by McCarty, and data from 2 other clinic-based studies suggested possible protective effects, relationships of statin. And this may be due to pleiotropic relationships where antioxidative lipid-lowering effects of statins are hypothesized to explain these findings. In a large case control study done in England here, with 18,000 persons with AMD and 86,000 controls, did not show a protective effect of statins. Neither did cross-sectional studies in the cardiovascular health study. And looking at both the Rotterdam study, Beaver Dam, and Blue Mountains combined showed no protective effect of statins, as did the complications of age-related macular degeneration prevention trial, or CAP. However, at the recent ARVO, the group from Australia did a study called the ARMS SS, which was a small 3-year prospective randomized controlled trial, 40 milligrams of simvastatin per day compared to placebo, and reported a benefit for reducing the progression of early but not late AMD. I need to see the data for this study. It's very small, and not sure this will hold up. Finally, in chronic inflammatory disease was mentioned, and the chronic inflammatory cells have been reported by Penfold and Sachs to be related to AMD, neovascular AMD, and drusen contain proteins associated with immune-mediated processes. The complement pathway through the genetic factors have been reported to be associated with AMD. I looked at the relationships epidemiologically, and you can see there's a lot of zeros there from various studies. In Beaver Dam, we did find, when we looked at the whole population, where we measured low albumin, a marker of inflammation, white blood cell count, and C-reactive protein, positive relationships between both the prevalence and incidence, suggesting a relationship. I don't have time enough to go into other factors, but I'd like to just mention that older birth cohorts, people born in earlier years, were the same age as people born later years. People born at a later period of time, when they reach, for example, 85, have a lower risk of developing early AMD than people who were born in previous periods. This remains despite controlling for changes in smoking, blood pressure, and other factors. Physical activity appears to be protective, with a 75% reduction in incidence of late AMD over a 15-year period. Iris and hair color, we've never found a relationship, nor did we find a relationship of refractive error or socioeconomic factors. And finally, the question, what is the chance of their siblings or children getting the disease? In Beaver Dam, there were 825 SIP-ships. The odds for the second sibling free of the lesions at the baseline exam, developing the same 5 years later as a sibling with it at baseline, was 8 times for RP depigmentation, 4 times for increased retinal pigment, and 10 times for neovascular AMD. And in the Rotterdam study, Claver and Associates showed that signs of early AMD in offspring of persons with AMD compared with offspring of persons without AMD was 7. We are investigating a number of candidate genes which have been recently shown to be related to incident AMD, such as complement factor H, ARMS2, C2, CFB, C3, and lipid pathway genes, as well as other candidate gene sites. And I think the interactions with the environmental risk factors will be very telling. So in summary, the pathogenesis of AMD is still poorly understood, though we know more than we did 25 years ago. Epidemiologic studies have provided new information on the natural history of AMD, and risks involved when early AMD is present, and showed strong relationships of age, family history, and smoking. Positive but less consistent associations have been shown with hypertension, pulse pressure, heavy drinking, and inflammatory markers. Statins remain controversial, as does cataract surgery, which Barbara Klein will present on Friday morning. And gene-environmental host interactions may provide better understandings of these relationships in the future. I think our objective is to prevent this stage of AMD, and I think epidemiology helps in the understanding of the factors that lead to development from early to late. But I agree with the first speaker that we really need to begin before the early AMD is apparent. Thanks.